Hello, everyone, and welcome to the November webinar. I understand it's just a few days before US Thanksgiving, so happy Thanksgiving to all of you in the US. I'm up in Canada. I am a hematologist and also treat patients who have primary immune defects. And we just are getting some snow today for the first time up here in Calgary, so it's a little frosty out there. But we'll get started with the case, and hopefully it'll be a good discussion. So this is a case that I first saw many years ago in my hematology practice, and I still don't feel like I have a good grip on what's going on with this person. And but I have a few clues, and hopefully we can kind of work through things together. I want to thank Dr. Cooper for agreeing to be my senior mentor at the very last minute, and also wanted to remind you just to put your comments in the attendee chat rather than in the live chat box, or in the Q&A. Sorry. Put it in the attendee chat, and we will address those as they come up. So this is a lady I met in 2015. She was 42 at the time and was referred to my clinic. A colleague of mine retired. She was being followed for some neutropenia and thrombocytopenia. Past medical history wasn't really exciting. She had some back issues from a ski accident and hysterectomy for menorrhagia, tonsillectomy. She did have a rectal abscess after her hysterectomy, requiring removal of a portion of her bowel, and a coli, as well as an unprovoked DVT. Really not on any meds, just some cortisone every 3 months. As far as her infection history goes, it does go back to childhood. She recounted ear infections and pharyngitis as a kid, requiring admission to hospital a couple of times. As an adult, at that initial appointment in 2015, she really talked about bladder infections, some abscesses of her gums that had been increasing in frequency for the past year, and needing antibiotics every few months. No real frequent pneumonias or sinus issues, no fungal or mycobacterial infections, no cold sores. She did acknowledge some shortness of breath on exertion, but no chest pain, and denied any gastrointestinal issues. As far as her neutropenia goes, it dates back to at least the 1990s. That's when she said she first became aware of it. She was treated with GCSF intermittently starting in about 2001, and then kind of 300 micrograms a few times a week, and then weekly. She didn't tolerate it well, and I found most patients don't tolerate GCSF at that dose on a regular basis, but going to a low dose, like even 50 to 100 micrograms, sometimes on a more frequent basis, can be effective and have fewer side effects associated with it. She actually had stopped it in 2014 because it just didn't make her feel good. She had a bone marrow biopsy done in 2000, which unfortunately I couldn't access, but it was apparently slightly hypocellular. As far as her social and family history goes, her mom, maternal grandmother, had breast cancer. Mom had cervical cancer at age 45 and survived. Paternal grandfather had a stroke. Her father had angina, and a grandmother had Parkinson's. She's a healthy sister and 2 healthy children. She works as a medical office assistant. She's a non-smoker, minimal alcohol, no drugs. And going back in her labs, I could go back as far as 2007 on our system. And at that time, her CBC was totally normal. Between 2010 and 2015, she just had intermittent neutropenia and a bit of lymphopenia. And when I saw her in 2015, her labs looked like this. So hemoglobin was low at 112. She was macrocytic, so large red cells. Her platelets were normal. Newts were kind of in the 0.9 to 0.8 range, and her lymphocyte count was also normal. So when I saw that low hemoglobin, I thought, okay, so I've got a macrocytic anemia. I automatically think, okay, are reticulocytes present causing this increased MCV? And so I did a hemolytic workup as well as just a workup looking for any other signs of B12 deficiency, folate, etc. She had a bit of a picture consistent with hemolysis and a bit of an increased retic count. Her haptoglobin was low. And as you may know, haptoglobin is a protein that kind of sweeps up. Someone once told me to think of it as a broom, and it kind of sweeps up the red cells that have died, and so it gets consumed. So in hemolysis, it tends to decrease. LDH was elevated, just not a huge amount. Upper limit of normal is 235, but a little bit increased. Her bili was normal though, and I did a direct antiglobulin test that was negative. And the rest of her workup for anemia was essentially negative as well. I did a serum protein electrophoresis in addition, and that was negative. Does anyone want to volunteer with their differential diagnosis for DAT negative hemolysis? And I know I'm giving you like a hematology lesson here, but I promise we will get to some immunology very soon. Yeah, so we've got microangiopathic hemolytic anemia, MAHA, PNH, and I'll go to my next slide here. So you've got your inherited disorders like sickle cell, thalassemia, G6PD deficiency, PK deficiency, the membranopathies where the cells aren't have an abnormal membrane shape and therefore are prone to destruction. Infections can do it. Drugs and toxins can do it. And then we get more into the more exciting stuff like the thrombotic microangiopathy, like TTP or HUS. I wasn't worried about TTP. There were no schistocytes on her blood smear. She wasn't presenting in an acute fashion. This was definitely a more chronic picture. DIC, HELP, malignancy, antiphospholipid syndrome, as well as structural things. So I've had a few patients where they've actually had valve-related hemolysis. Splenomegaly can cause some, and liver and kidney disease. So in my patient, her hemoglobinopathy screen. Yes, that is true. It can still be immune mediated, um, despite with an IgM, but not terribly common. Um, and she had no schistocytes, spleen was normal, no liver or kidney disease. So there's one thing that I left off this list that someone in the chat had mentioned, and that was actually PNH. And so PNH is, if you're not aware of what it is, I'll just give a brief overview. It's a hemolytic anemia that results in intravascular hemolysis. So in our normal steady state, our red cells have little flags on them, CD55 and CD59, and those act as kind of like a stop sign to the complement system. And if you don't have those, then your red cells and other blood cells are prone to destruction by the complement mediated system through the MAC attack complex. So these PNH patients are missing CD50, 55 and or CD59, and that results in these clones. So we can measure these cells that are lacking these markers. So she gets small clones like granulocyte 3.64, monos were 2.32, erythrocyte type 2 was low, and type 2 they have some expression, and type 3 they have no expression. And so I see PNH as well. So this was within my wheelhouse. And I'm like, okay, those are small clones. So for me to really think that this is going to be hemolytic anemia related to PNH, I typically see clones over 70%, like granulocyte and or monocyte. They typically have LDH greater than 1,000. Their bili is up. Their retic count is up. And that really wasn't what I was seeing here. Question about any supportive findings on peripheral smear to rule out. Oh, I can't see. Sorry, I'm trying. Oh, here we go. To rule out. No, really nothing on her smear other than neutropenia, and no evidence of dysplastic cells. So I'm kind of thinking, okay, that we've got some PNH here, but PNH clones, but I don't think it's clinically significant. So did a bone marrow biopsy. So now she's got a hypercellular marrow with megaloblastoid erythroid hyperplasia. So this means she's got a lot of red cells and they're kind of big, and she's got 90% cellularity. So cellularity typically is 100% minus your age. So at age 42, I would expect her cellularity to be somewhere in the like 70% range. And she had 90%, majority of them being erythroid in lineage, some small hypolobated megakaryocytes, decreased granulocytes, and like Leo is saying, is this MDS? And so I'm like, that's what I was wondering, is this MDS? She had normal cytogenetics, and we actually did on a subsequent marrow, which I'll talk about later, some next generation sequencing looking at myeloid panel, and that was negative as well. So really, I didn't get a lot other than to say, okay, I've got increased red cell production, which would be in keeping with the hemolytic anemia, but I don't really have a cause for the hemolysis or kind of why or where it's happening. So I went on to do an immunologic workup, just given her history of infections, and her immunoglobulins were all great, well within normal range, normal IgE. She had some abnormalities in her T and B cell subsets. So her CD4 count was a bit low. She had elevated CD8s and low memory and naive CD19 positive cells. NK cells were low, and she had an elevated number of NKT cells. I checked her vaccine responses. Just a few of them. Actually, when I was looking back, I'm like, why didn't I do more of those? But her rubella titer was protective. She had immunity to varicella and measles. I ultimately did a pneumococcal challenge with her, and her response was okay, kind of like 50-50, but so not great, but also not terrible. She had some other assessments kind of in and around this time. She saw cardiology for palpitations and dyspnea, and their workup was negative. She had no evidence of pulmonary hypertension and no evidence of LV dysfunction. So the pulmonary hypertension is kind of interesting because it is something that can go along with PNH. She saw rheumatology as well. She was HLA-B27 positive, but no evidence of an autoimmune disease or inflammatory spondyloarthropathy. There was perhaps some symptoms of spinal stenosis, but they really just kind of saw her like one more time and then discharged her. So we have a woman in her 40s with what looks like a hemolytic anemia. And I'm now thinking, okay, I'm not seeing schistocytes or breakdown outside the bone marrow. Has she got kind of an ineffective erythropoiesis or intramedullary hemolysis going on? She's got neutropenia. We've got low CD4s, increased CD8s, and increased NKT cells, low NK and B cells, and I'd say suboptimal polysaccharide vaccine response. Any comments or questions at this point? Okay, I will carry on. What would you do next? NGS panel, okay. ALPS panel, whole exome sequencing. So at the time, this was 2016, we didn't have the same access to genetic testing as we do now. I talked to my colleagues in myeloid disorders because I was still thinking about an evolving MDS. I checked her telomere length as well. So that's associated with dyskeratosis congenita and TERT and TERK mutations, which can result in various types of hematologic issues. She actually had short telomeres. So her telomeres were less than the first percentile for her lymphocytes and granulocytes. I did send DNA to Cincinnati to look for a bone marrow failure disorder at that time. I previously started her on some low dose GCSF and she was tolerating that and having fewer infections. Yep, no, we can definitely see short telomeres and other non-DKC disorders for sure. Started EPO injections as her hemoglobin was dropping below 80 and she was now needing some transfusions. She ultimately ended up stopping this in September 2019. So the genetics showed a mutation in SLX4, which is associated with Fanconi. I spoke to a physician who'd published on that particular mutation. She didn't feel it was pathogenic. I did chromosomal breakage studies just in case, and those were normal. Did her HLA typing as well for possible stem cell transplant, just thinking in the future, wanting to know what our options might be. And her sister was typed and was unfortunately not a sibling match. So it's now 2017. How is our patient doing? She feels unwell. She's unhappy that she's transfusion dependent, or she is happy that she's transfusion independent with the EPO. Shortness of breath on exertion, even when her hemoglobin's pretty good. She's very fatigued. She's noticing some bruising and gingival bleeding. Her coags are normal. Platelets are okay, so I don't have a good etiology for that. Still getting infections, skin infections, ear infections, UTIs, some perianal abscesses. And she's kind of been on and off the GCSF. She wasn't 100% convinced it was working and she'd kind of go on and off it. A couple new medical issues came up in 2018. She was having some atypical migraines, normal MRI and MRA, however. And she had a full thickness tear of her hamstring from the ischial tuberosity after a fall requiring surgical repair. So nothing that I think was related to any of her other disorders. I don't think it was consistent with Fanconi. But yeah, GATA2 is a good thought. I'm just reading from the chat here. So now I'm going back to her lab. So her haptoglobin remained inappropriately low. Her retics are inappropriately normal now. They are no longer elevated. She's got a hemoglobin kind of in the 90s to 100s. She's on the EPO replacement. Platelets are now dropping. Neutrophils are lower, and her lymphs are still okay. And I'm sorry, but the buttons are covering up the last line here. I think that's her LDH at the bottom. So you can see it's sort of fluctuating. It's going a bit higher into the 400s. I did her TB and NK cells a few times, and I just put them all on one slide for the sake of convenience. So you can see her CD3 count still normal. CD4s are still low. CD8s are still increased. NK-like T cells are increased. CD19s are low, and her NK cells are generally also still low. Immunoglobulins remain normal. And someone's saying recheck the PNH clone size. Absolutely. So I did some repeat bone marrow biopsies. So in 2018 and 2020, I marrowed this poor girl again, similar to previous. So some erythroid hyperplasia, moderately decreased granulopoiesis and megakaryopoiesis, increased vascularization and plasma cells, mast cells, and a few lymphoid aggregates, which the hematopathologist felt were suggestive of. She thought it was maybe an immune dysregulation disorder. No variants of significance on a myeloid panel that was done. I did check her for HIV, and she is negative on a couple of occasions. So I went back to the PNH. So she was telling me in clinic, I'm having more shortness of breath. She talked about dark urine in the morning, some difficulty swallowing. Patients with PNH can get smooth muscle dysfunction, and that's a result of nitric oxide scavenging the free hemoglobin. And so when you consume all that nitric oxide, you end up with things like difficulty swallowing, erectile dysfunction, sometimes pulmonary hypertension. So hearing these symptoms, I'm like, this still is not totally convincing me that this is PNH, that she doesn't look like my other PNH patients. But her LDH actually went up to 932 at one point. I did a CTPE because of her shortness of breath and just thinking increased risk of thrombosis with PNH, which is one of the other manifestations and can occur at low clone sizes. No clot there. Did a echo looking for pulmonary hypertension. She had normal systolic function. Her tricuspid jet velocity was slightly elevated. I did speak to one of my colleagues in the pulmonary hypertension world who said not that exciting, wasn't that excited about it. I did not consider metabolic conditions such as cobalamin C disorder and complement inhibitor time. I think Leo's on the right track here. So I'm sort of at a loss. She feels like crap. I don't know what else to do. Again, she's not looking like, I see all the PNH patients in Southern Alberta, and she doesn't look like any of those, but like, well, these clones actually meet criteria in our province that's greater than 10%. She actually had a drug plan that would cover eculizumab. So that's what I did. So I started that in April of 2021. She felt a bit better. So she had less shortness of breath and chest pain. In the meantime, we now had, in the last few years, we've had more access to genetic testing. Blueprint has this nice comprehensive cytopenias and immune deficiency panel. So I thought, what the heck, let's see if anything has evolved over time, and sent that off as well. So I found a gene that is associated with immune deficiency or dysregulation. And I think we've got some differential diagnoses in the chat there. So, I'm unfamiliar with cobalamin C disorder. GATA2 has come up. There's other non-dyskeratosis disorders that can cause short telomeres. So what I actually found was a STAT3 gain of function mutation. So this tyrosine 640 phenylalanine mutation was present. So the question is, does this explain her phenotype? And what would you do next? Phosphorylation studies. Did I run it on peripheral blood? Yes, I did that. We sent blood to Blueprint whole blood, STAT3 phosphorylation. So I talked to Josh Milner, and I also talked to the hematopathologist who read her last marrow, and we'll kind of get into why I did those things in a bit. I did check her STAT3 phosphorylation. It was normal. I did Th17 enumeration, which was also normal. And we know those things can be normal in STAT3 gain of function mutations. I stopped her eculizumab at that point. Adrian is asking about LGL clones. So no. So this is why I went back to the hematopathologist, because I wanted to know, is there anything that would lead us towards an LGL diagnosis in this patient? And she looked at the marrow again. She said, no, I actually don't even see enough here for me to consider doing T-cell clonality studies.
Jen, can I just say something here? Because a couple people brought up STAT3 phosphorylation, which
please go ahead.
is a great thing to think about. However, I do want to make the point that in STAT3 gain of function, essentially none of the variants described to date have hyperphosphorylation. So you could sometimes see some subtle defects like delayed dephosphorylation, but you're generally not going to see hyperphosphorylation. So a phosphorylation assay for STAT3 gain of function is probably not going to be that helpful and would not rule out the diagnosis. As opposed to STAT1 gain of function, where there are a significant percentage of those patients and mutations where they have hyperphosphorylation.
Thank you, Dr. Cooper. So this slide just kind of goes over differences between loss of function and gain of function in germline mutation disorders of STAT3. And so we typically see increased IL-6 signaling. Says there can be some abnormalities with phosphorylation, decreased Tregs, and we know that the STAT3 gain of function mutations can cause an ALPS-like phenotype or IPEX, or they often have autoimmunity, repeated infections, low immunoglobulins, reduced switch memory B cells, whereas our Job syndrome, autosomal dominant hyper IgE syndrome patients are quite a bit different. And this is just going further into the gain of function phenotype. The largest study, 42 patients, they often found hematologic disorders. These were autoimmune cytopenias, and this patient does not. She might have an autoimmune thrombocytopenia and neutropenia, though she did have decreased precursors in her marrow. It's hard to say. They often can have immune deficiencies, as outlined there, and then the lymphoproliferative aspect, as well as the autoimmune disorders. So really, is she meeting a lot of those criteria? Some, but it's not a slam dunk. In the somatic mutations, STAT3 mutations are frequently found in patients with T or NK cell lymphomas, as well as T cell LGL. And LGL is kind of an indolent lymphoproliferative disorder. It's usually associated with rheumatoid arthritis, and these people are often old. Like they get it when they're 60. They've had rheumatoid for a while, and they develop this LGL. In rare cases, they can have autoimmune cytopenias. There can be other hematologic disorders associated, like lymphoma or a monoclonal gammopathy of uncertain significance, myelodysplastic syndrome, pure red cell aplasia. Those are not very common. Only 10% of patients are under 40 at diagnosis. They do often present with neutropenia, and anemia and thrombocytopenia can occur. They usually have a lymphocytosis. I had one of these guys recently that had this weird NK cell LGL thing, and he had quite a profound lymphocytosis. Diagnosis can sometimes be made on flow of the peripheral blood, and I had flowed her peripheral blood previously, and flow cytometry for marrow really didn't show any clonal populations at all. Most of them have marrow involvement, so doing the biopsy should have picked it up. They often have splenomegaly, usually no lymphadenopathy. You're going to treat them with cyclosporin, cyclophosphamide, or methotrexate. I had one of my X-linked AGAM patients actually get a T cell LGL in his liver. And that was kind of my experience with immune deficiency and LGL outside of the purely hematologic realm. In a study of 181 patients with LGL, 36% of the patients had mutations in STAT3. And the severity of neutropenia actually correlated with the presence of this mutation that my patient has. It didn't affect prognosis. They were more likely to respond to a JAK inhibitor. In another study, they found mutations in STAT3 in about 40% of the LGL patients, and 13 of those actually had patients in this same area, had mutations in the same area. This mutation has also been found in some patients with pure red cell aplasia, with and without T cell LGL. And the STAT3 mutation positive patients had more lymphocytes, more CD8 positive T cells, more common TCR gamma rearrangements. And they've also found STAT3 mutations in aplastic anemia and MDS. So which phenotype best matches the patient? When Dr. Cooper and I were discussing the case, she said, well, yeah, like what this is looking more like a somatic. And I said, yeah, but the problem is I've done 4 bone marrow biopsies on this woman. She has good production of her red cells. There's no evidence of PRCA. She has a hypercellular marrow. She's definitely not aplastic. She doesn't look like she's evolving in that direction. There's no evidence of myelodysplastic syndrome in any of her bone marrows. And as per hematopathology, they said, yeah, this is not a T cell LGL. She does have PNH clones, and we know those can be associated with MDS and aplastic anemia. On the germline side, we see the infection susceptibility, the decreased TB and NK cells, and cytopenias. So what would you do next? So we have performed functional studies, delayed STAT3 dephosphorylation. So I could see if our flow lab could do that. Skin biopsy would be another way just to confirm germline. We are still waiting for studies on her parents. Those have been sent. I did send her to genetics. Dr. Cooper, do you want to jump in here?
Sure. So in terms of functional studies, this is an interesting mutation, as you noted. So this is actually a phosphorylation site. And was a really nice paper that looked at mutating this phosphorylation site and demonstrate that if you mutate this phosphorylation site to the exact mutation that your patient has, and that is common in
Mhm.
LGL patients, and as you said, that it actually this phosphorylation site functions as a negative regulator. So unlike the way that we often think of phosphorylation as, okay, phosphorylation events, it's activating STAT3, this phosphorylation site actually helps to kind of almost destabilize the homodimer. So if you can't phosphorylate at that site, you have a more stable homodimer and you are more likely to have increased STAT3 activity. So we had a conversation by email too, and it's interesting to see the data from the LGL patients, but I was almost wondering if maybe a JAK inhibitor might not be as effective in this patient. So you still have to
Mhm.
phosphorylate the more canonical site, which I think is probably what Josh had tested, the Y705. So you could inhibit that with a JAK inhibitor, kind of that initial event, but it's not going to affect this inability to kind of negatively regulate STAT3 activity. It is intriguing, I think, that your patient seems to have this germline variant, but I think it's a great point that someone brings up to do a skin biopsy. I would
Mhm.
absolutely think about a skin biopsy in
Yeah.
this patient. I'd also think about family studies. If her parents, or I think there was a sister you said that you had to done bone marrow, looked at for a bone marrow match. I think that would be great to do because I do kind of wonder if it's smoldering. But I would guess if they called it and as a variant to you, that it's
Yeah.
probably close to that 50% allele frequency, and it's hard to imagine that close to 50% of her cells. But I you also go back to blueprints and say, what was actually the variant allele frequency of this variant that you called?
Yeah.
Depending on where they have their algorithm set, like, are they going down to 20% or what are they going down to, and kind of look at that. But I think the skin biopsy would be great.
Yeah, that's a good idea. I think we're still, as I said, still waiting for the testing on her parents, but
Mhm.
but yeah, it's I think doing the skin biopsy regardless in case this is a kind of spontaneous mutation. Why did I stop the eculizumab? Because eculizumab is A, very expensive. That's not the primary reason, but B, it wasn't help. I don't think it was targeting what we needed to target. And yes, she is at an increased risk of thrombosis, but her clones are not huge. And typically, I wouldn't treat someone like this unless they had kind of the florid hemolysis or they had a clot. So she's never had a clot. We're monitoring carefully for that. But in the absence of that, and in the absence of really a brisk PNH related hemolysis, I wouldn't treat her with eculizumab if there's an potentially alternate explanation for what we're seeing. So what I did, so I decided, what the heck, I'm just going to start her on ruxolitinib and see what happens. So and Dr. Cooper did send me that article about how this may not actually be an effective medication for her. But I thought, what have I got to lose? Her drug plan was willing to cover it, so she feels a lot better. We're not entirely sure why. She's less short of breath. She's got more energy. She's less fatigued. Her blood counts have improved a bit. Her platelets are now closer to normal, and hemoglobin is a bit better, but it's still kind of in the 90 range. And so that's kind of where I'm at with her. Ashish is asking about the family history of cancer relevant. I mean, it really was her mom that had the cervical cancer at age 45, which I don't think is too abnormal. I think it was the grandmother that had breast cancer, and I could find out the age on that. There was nothing that stood out, but it's something I could definitely revisit. And Rachel is asking if tocilizumab is used in STAT3. It can be. Um, Dr. Cooper, I don't know if you want to comment on that.
Yes, and that's what we use in some of our early STAT3 gain of function patients. And really, tocilizumab is trying to block IL-6 signaling, which is one of the main cytokines that signals through STAT3, but it's obviously not going to get all STAT3 signaling. So I agree that going with a JAK inhibitor, I think ruxolitinib is a great choice. I mean, so your ruxolitinib is still going to prevent that recruitment and initial phosphorylation and active dimer formation. So I think that I think that it could work. I think I'm just this variant is certainly pathogenic. There's no question, based on disrupting that phosphorylation site. So I think that I'm suspecting she might need some more definitive therapy, which seems like you've already been kind of thinking about in her for quite a while now. But if she's doing great on ruxolitinib, that's wonderful.
What would be your second choice or
Um,
first?
so honestly, I would probably maybe think about a bone marrow transplant in this patient
Yeah,
with such a strong hematologic phenotype. She doesn't really have any of the other autoimmunity. She doesn't seem to have. Well, do you think she has any lung disease or
I
no?
don't.
This is
I
a
have
pulmonary
CT'd her
hypertension.
chest a couple of
Mhm,
times. There was nothing there. I actually had put in a referral for her to pulmonary, and she just said, "Yeah, you know what? I'm feeling good right now. I don't want to do it."
mhm.
Because I actually, now that I think about it, I had done PFTs on her, and I think I can't remember what they said off the top of my head. I should have looked at that. But yeah, I felt there was enough just based on her symptoms to warrant a consult. But she didn't want to pursue that at this time. So that's still something we can look at. Pulmonary fibrosis. Yeah, I don't think she had a restrictive defect in her PFTs, but I could check. Has MDS been reported? Yes. So that particular mutation that she has been associated with myelodysplastic syndromes. And I've told her we're probably going to end up doing more bone marrow biopsies because I think this is just going to evolve over time. But she's just enjoying feeling better right now, and so we're sort of taking it one step at a time. But we have discussed bone marrow transplant on several occasions, and she knows that may be in her future at some point, and she knew that no matter what we found on genetics or with anything. But I think she's sort of hopeful that the rux might keep her feeling well for a bit longer. We're trying to titrate up the dose, but of course you have to watch for cytopenias, so she doesn't need more of those. Yeah, interferon 1 activation. Would you see any evidence of type 1 interferon activation on monocytes with gain of function, STAT3 gain of function?
I don't. We have not looked at. I'm trying to look at the question here. We have not looked at the ISG signature in these patients, and I'm not sure that anybody has. But type one interferons can signal through STAT3, and so you could imagine that.
I think we lost you, Dr. Cooper. I can't hear you.
Regulator of STAT signaling, and so that's a good thought to think about the overlap there.
And then our next question was, is she on any prophylaxis? So I do prophylax my PNH patients with penicillin, which is the other reason actually why I stopped the eculizumab, because it does put people at risk for meningitis. And even though people are vaccinated, we're kind of finding that the vaccines aren't 100% effective. Obviously, they don't cover all serotypes of meningitis, but they also, even I've had a patient develop meningitis with having been vaccinated and having a serotype that was supposedly covered by the vaccine. So the Leeds group out of the UK does recommend penicillin or other prophylaxis against meningitis for this population. So when she was on the eculizumab, I had her on Prof. Right now, she's not on any prophylactic antibiotics. She is taking the GCSF right now and hasn't been having too many infections, which is good.
And there's only a handful of these germline variants at this location that are typically somatic, and I think the other one was a child with Evans syndrome, and the other one was a patient with a hypereosinophilic syndrome. So again, both kind of hematologic phenotypes rather than
Yeah,
kind of the polyautoimmunity that we think about with STAT3 gain of function.
definitely. And yeah, there's nothing to suggest a hypereosinophilic syndrome on her bone marrow, and no kind of nothing consistent with Evans in terms of splenomegaly also being present. So yeah, so I will pursue um, the skin biopsy and perhaps contacting Blueprint about the variant allele frequency just to get some more
Yeah.
information.
You might also think about pushing your hematopathologist a little bit to look for T cell clones.
Yeah, I kind of did at the time.
You know,
She was pretty reluctant, but it would be worthwhile doing those studies.
Yeah, because there have been some germline STAT3 patients with LGL. The other disease that we're interested in my lab, TLR8 gain of function.
Mm,
There's been one of those patients with LGL and another with a kind of evolving LGL with a dominant clone. And I'll say, like, looking at the marrows with the hematopathologist for those cases, they said, well, it obviously can't be LGL because this person's only 18 years old,
mhm,
um, which we know is not the case with these mutations.
right. Okay. Any other questions or comments? All right. Well, with that, I think we'll close for the evening. We get a short a short day today, and again, happy Thanksgiving to everyone in the U.S. And thanks for your comments and for the discussion.